I'm Michael Wechsler, Professor of Medicine, Director of the Asthma Program, and Co-Director of the Cohen Family National Jewish Asthma Institute in Denver, Colorado. Eosinophilic granulomatosis with polyangiitis, EGPA, is also known as Churg-Strauss syndrome, and it's a complicated syndrome characterized by asthma, high levels of blood eosinophils, sinusitis, pulmonary infiltrates, neuropathy, and vasculitis in one or more end organ. There are 500 to 1,000 new diagnoses of EGPA every year in the United States. The patients who are at highest risk of developing EGPA are patients who have long-standing asthma or adult onset asthma, who over time may develop sinus disease, pulmonary infiltrates, and eosinophilia. And it's those patients who may develop high levels of eosinophils that may infiltrate the tissue that may be diagnosed with this syndrome. The standard of care of patients with EGPA is treatment with systemic corticosteroids. And in those patients who continue to have either continued symptoms or high levels of blood eosinophils, then other therapies are used, including cytotoxic agents like cyclophosphamide or azathioprine, or in other cases, methotrexate may also be used in certain patients. The problem with those therapies is that they all have some degree of toxicity, and they may not be all that effective in terms of treating the underlying disease. Many of these patients suffer from side effects of systemic corticosteroids, and what happens to these patients is that they end up having all these complications and try to get off of corticosteroids unsuccessfully. The study we performed in patients with EGPA was to explore the efficacy and safety of an anti-IL-5 monoclonal antibody, Mepolizumab, in patients with EGPA. These patients were randomized to receive either Mepolizumab, given subcutaneously once a month, 300 milligrams each dose, or placebo. They received these therapies over the course of a year, with the goal being to identify an improvement in remissions, reduction in corticosteroid dosing, and prevention of EGPA-associated relapses. We ended up enrolling 136 patients who were randomized 1-to-1 to receive Mepolizumab versus placebo. These patients were enrolled from 31 academic medical centers in 9 countries, although the majority of patients came from the United States. A total of 136 patients were randomized in this study, 1-to-1, to Mepolizumab versus placebo. The primary endpoints were the proportion of patients who were in remission for at least 24 weeks during the study, as well as the proportion of patients who were in remission at both weeks 36 and 48. Mepolizumab outperformed placebo with regard to the proportion of patients who were able to achieve at least 24 weeks of remission. 28% versus 3% of patients treated with Mepolizumab had at least 24 weeks of remission. With regard to the other primary endpoint, the proportion of patients who were in remission at weeks 36 and 48, again, Mepolizumab outperformed placebo. 28% versus 3% of patients treated with Mepolizumab were able to achieve remission at both weeks 36 and 48. Approximately 50% of patients treated with Mepolizumab were able to achieve remission versus approximately only 19% of patients treated with placebo. In addition, in patients treated with Mepolizumab, there was approximately a 50% reduction in the exacerbation rate compared to placebo. And importantly, many patients were able to taper their corticosteroid dosing with Mepolizumab compared to placebo. While approximately 50% of patients received significant benefit with Mepolizumab, about half the patients in the study failed to achieve the primary outcomes. It's important to ask why this was. First of all, it could be because in those patients, they may have a different form of vasculitis. They may have adrenal suppression, and that prohibited for safe reduction in corticosteroid dosing. Or perhaps those patients may have benefited from a higher dose of Mepolizumab compared to the 300 milligrams given once monthly. In prior studies with mepolizumab, 750 milligrams intravenously was given, and perhaps that dose could have fared better in this study. All of these patients were on a dose of prednisone of at least 8 milligrams a day from the get-go. One of the major goals of the study was to taper down from the dose of prednisone that they were started on down to a dose of less than 4 milligrams a day. Many of these patients continue to require corticosteroids. However, what we observed was that about 20% of patients were able to come off of corticosteroids completely in this study when they were treated with mepolizumab, versus only about 3% who were treated with placebo. This significant steroid-sparing benefit we view as an important outcome for patients as well as for providers.